All right, let's talk about hospice care. There's a really big shift happening right now. We're moving away from the system we've known for years, the HIS, and we're jumping into something brand new called HOPE. So let's dive in and break down what this actually means for everyone involved.
Here's how we're going to tackle this. First, we'll get into the whole philosophy behind this change. Then we'll walk through the new timeline for collecting data, see how it actually forces us to act on patient symptoms, cover some of those tricky what-if scenarios, and then, of course, we'll talk about compliance and how to survive the transition. Okay, first things first. It is so important to understand that HOPE isn't just another form to fill out. It's a totally different way of thinking about how we document care. It's a fundamental shift in philosophy. This slide nails the difference perfectly. Think of the old HIS system like a game recap. You're looking back after the fact, asking, okay, what could we have done better? It was all retrospective. HOPE, it's the complete opposite. It's a live playbook. It's designed to be used in the moment to answer the most important question there is. What does this patient need from me right now? And that's exactly what its name stands for: Hospice Outcomes and Patient Evaluation. The entire point is to evaluate the patient in real time to improve their outcomes, getting them the care they need when they need it. It's all right there in the name. So you might be wondering, who does this apply to? The answer is pretty much everyone. We're talking about all patient admissions to any Medicare-certified hospice. It doesn't matter if it's Medicare, Medicaid, or private insurance. It doesn't matter how old the patient is, where they're living, or how long they're in your care. This is the new standard, period. Okay, so that's the big idea. But what does this actually look like in practice? Well, that brings us to the HOPE life cycle, which is just the fancy way of saying the new schedule for when you have to collect this data. Instead of just bookending the patient's stay with data, HOPE adds new checkpoints in the middle. You've still got your admission and discharge records, but now we have these two new things called HOPE update visits, or HUVs. These are designed to give us a much clearer picture of the patient's entire journey with us. So what is a HUV exactly? It's a required in-person assessment that has to happen within very specific time windows. This is the engine that drives the whole real-time thing. It's how you formally capture what's going on with a patient during their stay, not just at the start and finish. Now, of course, the real world is messy. Not every patient is going to hit every single one of these checkpoints. It all comes down to their lengths of stay. Say a patient is admitted and passes away on day 4. Well, that's before the first HUV window even opens, so you'd only need to do the admission and discharge records. It's logical. And this is where that real-time data collection starts to have some serious teeth. This leads us to probably the single biggest change to day-to-day clinical practice that HOPE brings: a brand new mandatory response to patient symptoms. So let's ask the big question. You're doing your admission assessment or one of those new HUIVs, and the patient reports moderate or severe pain or some other tough symptom. What do? What does HOPE require you to do now? The answer is something called a symptom follow-up visit, or an SFV. And listen, this is not optional. If that assessment flags a moderate or severe symptom, you are now required to go out and conduct a separate in-person visit just to follow up on that specific issue. It creates a direct, documented link between the data you collect and the action you take. And you're on the clock. That follow-up visit has to happen within 2 calendar days. This really drives home the new emphasis on being responsive and proving that you're addressing patient needs quickly. Now, here's a really important clarification. For reporting purposes, you only have to do one SFV for that symptom. If you do the visit and the symptom is still there, you don't have to keep logging more SFVs in the system. But, and this is so important, your clinical and ethical duty to keep managing that symptom obviously doesn't go away. This is just about the reporting requirement. Okay, so we've got the basics down, but we all know hospice care is filled with curveballs. So let's talk about how HOPE works in some of those more complicated real-world situations, like when patients move around. When it comes to administrative discharges, there's a pretty simple rule of thumb. If the patient is still in your care, meaning there's no break in service, you generally do not have to file a HOPE-Discharge record. So think about things like a payer source changing, or even a missed face-to-face encounter. If the patient is still on service, no discharge form is needed. And this table does a great job of breaking down the difference between a transfer and a traveling patient. If a patient actually transfers to a new hospice, both you and the new hospice have to submit your own full set of HOPE records. But if a patient is just traveling for a bit and staying admitted with you, their home hospice, then no new admission or discharge records are needed. Makes sense, right? All right, all of these new rules and workflows eventually lead us to the bottom line, right? Compliance. So in this last section, let's talk about what you absolutely need to know to get this transition right. First thing to remember is that the Hospice Quality Reporting Program is what they call a pay-for-reporting program. What that means is you get paid for submitting the data on time. Your compliance isn't based on the patient's outcomes, but on the simple act of getting the forms in when they're due.
And you're going to want to take this seriously because the penalty is steep. If you fail to submit at least 90% of your required HOPE records on time, you're looking at a 4 percentage point reduction to your annual payment update. That's a huge hit, which means getting these new workflows locked down from day one is absolutely critical.
So how is this whole thing going to roll out? Well, for any patient discharged before October 1st, 2025, you're still on the old HIS system. Now, for that confusing group in the middle, admitted before October 1st but discharged after, you'll do an HIS admission and a HOPE-Discharge. No HUVs for them. Then for any admission on or after October 1st, 2025, it's all HOPE. That's the new world.
And this quote from CMS really circles us back to the whole point of this massive undertaking. The goal here is to get a much better moment-to-moment understanding of the patient experience. It's all about gathering better data during the stay so we can get better at providing quality care. So, as we wrap up, I'll just leave you with this question to think about. We've gone over the forms, the deadlines, the rules. But the real question is, as we make this shift from looking backward to actively guiding care in the moment, how is this going to change not just our paperwork, but the fundamental rhythm of how we deliver patient care? Something to think about. Thanks so much for joining me.